An evaluation of staffing ratios for registered nurses in acute care hospitals. My name is Vicki Ann Adams, and together with Jacqueline Tyler and Sabrina Quills, I will present to you an overview of the issues surrounding nurse staffing ratios, focusing primarily on the acute care hospital setting. We will explore some general background, a review of available literature, and then cover some of the key legislation on the topic. Finally, we will present some recommendations for going forward. First, a brief introduction to the general topic. Nurses are one of the largest healthcare providers in the profession and consist of registered nurses, licensed practical nurses, and unlicensed nursing assistants. Because the population is living progressively longer, supplying enough nurses to meet the demands of our growing population is becoming more and more of a challenge. The implementation of the Affordable Care Act in 2010 granted access to health care for many Americans who were previously uninsured or underinsured. These changes led to patients with more medical complexities and chronic conditions because insurance companies are no longer allowed to deny access to anyone due to comorbidities. Additionally, as the aging population continues to grow, the number of qualified nurses is decreasing, and there may not be enough nurses to meet the demands of the population. In this section, we will provide a brief overall picture of the issues behind nurse staffing. Common staffing models. To assist hospital management's decisions regarding staffing, there are three main models currently used to determine staffing levels. These are budget-based, nurse-patient ratio-based, and patient acuity-based. Most facilities rely on a combination of these models to determine the amount of staff necessary for any given shift. Budget-based staffing is the easiest of the three to understand. It uses historical data to determine the average number of nurses required to care for an average number of patients. It does not consider dynamic changes in the number of patients throughout a shift. The nurse-patient ratio model is based only on the number of nurses on a particular unit. Once a ratio is established, for example, 4:1, there must be one nurse assigned for each 4 patients on the unit, without exception. The biggest issue with staffing based solely on ratios is that once the nurse-to-patient ratio is met, no additional patients can be admitted to that unit. This can lead to patient backups because the hospital must continue to provide treatment regardless of inpatient ratios, and patients can be forced to wait in the emergency room until open beds are available. Staffing based on patient acuity is the most difficult model because it assigns staffing needs based on the amount of care a patient may require, which can be incredibly subjective and hard to quantify. The 1996 Institute of Medicine study, Is Nursing Staffing Adequate? The overall focus of this study was to look at the rapidly changing healthcare industry and the roles and responsibilities of registered nurses in the changing environment. It highlighted the growing shortage of professional nurses in the United States and the overall impact registered nurses have on quality patient care. It is important to remember that this study occurred more than 20 years ago and does not take into account any changes that became mandatory because of the Affordable Care Act. Nurse staffing impacts many areas. We will highlight its effects on patient safety, quality healthcare delivery, and overall costs. Impact on nurses and patient safety. There are multiple studies that indicate that by establishing minimum nurses to patient ratios, patients respond well with decreased length of stay and a reduced risk of developing a hospital-acquired infection. Understaffing reduces the overall time nurses can spend with their patients and leaves new nurses without adequate supervision, both of which puts patients at risk for adverse outcomes. The impact on quality healthcare delivery. Unfortunately, with the many factors that impact the nursing profession, increased pressure is placed on nurses, and companies are mandating overtime to ensure nurse availability during high demand, which increases nursing workload. High workload in the form of time pressure may reduce the attention devoted by nurses to safety-critical tasks, thus creating conditions for errors and unsafe patient care. Under high workload, nurses may not have time to follow rules and guidelines for safe care, especially if following the rules and guidelines necessitate additional time, such as hand washing. Nurse burnout creates a domino effect. Hospitals start to experience high turnover, poor job performance, and quality patient care is threatened, and at the end, cost increases because the hospital has to pay for new recruits, as well as provide incentives such as sign-on bonus, tuition reimbursement, and help to pay off student loans. Due to mandated overtime and nurses experiencing burnout, some nurse professionals start to seek employment in other settings or completely change careers. Impact on costs and budgeting. A study conducted by Kunin, Norrish, and Rundle indicated that, as a result of restructuring and increasing attention to costs, many hospitals have chosen to decrease their overall labor pool, including the number of full-time nursing positions. With nurses being the largest group in the healthcare industry, they are usually the first staff to be reduced. And without adequate nursing staff, the hospitals are forced to use temporary nursing staff, which affects continuity of care for the patients. Since nurses are the largest group of employees, they are usually in the forefront to be reduced, not realizing the long-term effects of not having adequate staff on the hospital and on patients. Hospitals that have a high incidence of hospital-acquired infections have to increase the budget for such events, and it forces hospitals to cut costs in other areas. In this section, we will examine some of the literature available on the topic of nurse staffing. What research says about nurse staffing? The literature search returned more than 150 total articles, and 12 articles were selected for evaluation and analysis. All 12 articles evaluated presented some proof that patient outcomes are driven by the number of nurses working any given shift. In the article, Nurse Staffing and Patient Outcomes, the data analysis showed a specific correlation between increased registered nurse staffing and a decrease in both patient falls and hospital-acquired pressure ulcers. Many of the article authors list the limitations of available data as a main issue with their research. Because it is impossible to separate out just nurse staffing as the causative factor for patient outcomes like falls, pressure ulcers, infections, and readmission rates, it is impossible to say that nurse staffing is always the driving force. Additional literature. The ANA White Paper. In 2015, the American Nurses Association, in collaboration with Avalere Health LLC, presented and published Optimal Nurse Staffing to Improve Quality of Care and Patient Outcomes. The overall purpose of this paper was to present an in-depth analysis of the nurse staffing topic. Published a few years after the rollout of the Affordable Care Act, this paper uses contemporary data to present the situation. The paper differentiates between fixed and flexible staffing models and presents the pros and cons of each model. Fixed staffing levels rely on established numbers or nurse-patient ratios. They are a blend of budget-based staffing and ratio-based staffing levels. The pro for fixed staffing models is its ease of use. The biggest con is that fixed staffing models do not consider patient acuity, staff skill level, or changes in patient census. Flexible staffing is much more adaptive, but is also difficult to accomplish. It considers patient census and patient acuity when determining the number of nurses required for quality patient outcomes. The Institute of Medicine, the Future of Nursing. There have been many reports released by the Institute of Medicine on healthcare, patient safety, and nursing. The Future of Nursing, released in 2011, is one such report. Consisting of more than 600 pages, the report offers recommendations that collectively serve as a blueprint to ensure that nurses can practice to the full extent of their education and training, to improve nursing education, to provide opportunities for nurses to assume leadership positions and to serve as full partners in healthcare redesign and improvement efforts, and finally, to improve data collection for workforce planning and policy making. Overall, the report reinforces the idea that quality patient care relies on access to registered nurses who are well trained and qualified for their position. Hospital nurse staffing and quality of care. Published in 2004, Hospital Nurse Staffing and Quality of Care is the oldest of the three key documents on the topic of nurse staffing. The paper supports the understanding that high-quality patient care requires the presence of an appropriate number of well-qualified registered nurses. One portion of the study evaluates care at 168 hospitals with an overall patient-to-nurse ratio ranging from 4 patients per nurse to 8 patients per nurse. In the hospital studied, 4,535 of the 232,342 patients examined died within 30 days of being admitted to the hospital. If the patient-to-nurse ratio had been just 4 patients for each nurse, possibly only 4,000 patients may have died in the same period. And had the ratio been as high as 8 patients for each nurse, more than 5,000 may have died. This key factor highlights the inherent risk to patients when nursing staffing is spread too thin. We will now take a brief look at the legislation history and variables that have occurred along the way. The initial legislative issue, condition of participation, nursing services. This existing law is the only federal law in the books concerning nurse staffing, and the language has been construed by nurses as being incredibly ambiguous. While the regulation states that hospitals should provide an adequate number of nurses, it lacks specificity, which nurses say contributes to nurse burnout and associated safety implications. The first meaningful change. California was the first state to require minimum nurse-patient ratios. Massachusetts followed with a similar mandate specific to intensive care units. Fourteen states have taken action to address safe staffing issues. More support is needed. As depicted by the shaded areas, some states have voluntarily enacted legislation supportive to the safe staffing agenda. As you can see, most states have not, which reinforces the importance of supportive congressional action. Supportive legislation and regulations tend to fall into three categories. Safe staffing minimum ratios. This creates a foundation to provide a maximum number of patients per nurse. Safe staffing disclosure and public reporting is used to gather data, inform the public, and prevent retaliation toward nurses that object to unsafe conditions. Finally, safe staffing committees empower nurses and provide for flexibility in their specific environment. However, when the responsibility is shared with hospital administrators, the ultimate decision makers, the nurse efforts can be undermined by financial goals. Changes have been slow. Multiple efforts die in committee. Several variations of legislation containing safe staffing language have been reiterated and reintroduced by the House and Senate. The proposed legislation has landed on the steps of Congress every year for the past 15 years. In fact, some bills have been reintroduced to Congress up to 7 times. Here are just a few examples of bills that died in committee. The National Nurse Shortage Reform and Patient Advocacy Act, the Registered Nurse Safe Staffing Act of 2014, the Registered Nurse Safe Staffing Act of 2015, the Nurse Staffing Standards for Patient Safety and Quality Care Act of 2015. Despite hospital resistance to hire more nurses due to costs, other factors are complicating the issue and preventing compromise. Proponents and opponents, hospital industry, and nurse union division. The success of California Code Register Title 22, Section 70217 created some friction between nurse unions relating to updating federal laws. Nurses agree that the California law provides value, but there is discord between nurse organizations concerning a federal mandate. The American Nurse Association substantiated hospital concerns to the effect that more than a nurse-patient ratio would be necessary to tackle this issue entirely. Alternatively, other nurse groups tout the success of the California law and hold that a mandated ratio provides a clear maximum number of patients a nurse can treat at one time, creating a floor or foundation, if you will, with which to build upon. The following testimony illustrates the point of view of the Connecticut Hospital Association. Based on the content of this testimony, the American Nurse Association has demonstrated that it is actively seeking a mutual compromise by addressing and supporting hospital concerns in the contemporary bills. Connecticut Hospital Association presented written testimony to the Public Health Committee opposing the 2013 Connecticut Senate Bill 968, an act concerning reports of nurse staffing levels. The Hospital Association rejected this measure because simply counting would not reflect the complexity and dynamic nature of the hospital environment. We've included the following link to the full testimony should you wish to peruse further. Connecticut Hospital Association testimony continued. Considerations must go beyond ratios and numbers. The Connecticut Hospital Association testified that recording nurse-patient ratios creates an unnecessary administrative burden and does not consider important variables that impact patient care. Factors mentioned are age, cognitive and functional abilities, severity of condition, scheduled procedures, and stage of recovery. Staff considerations include education, licensure, tenure, and skill levels relating to particular types of care, situational factors such as technology, needs, and availability, and the physical layout of the patient unit. Overall, they explain the needs for flexibility to accommodate for changes in census, acuity, and the specific care needs of patients because, in reality, hospital staffing levels and skill mixes are consistently adjusted throughout the day. The Patient Protection and Affordable Care Act became law in 2010. The Affordable Care Act was enacted in the midst of the Nurses Safe Staffing Crusade. 3 programs, value-based purchasing, hospital-acquired condition reduction, and hospital readmission reduction programs significantly impact healthcare delivery and therefore nurse activity. The general spirit of these programs was to improve health outcomes by financially rewarding positive outcomes and financially penalizing hospitals that do not meet established outcome criteria. Basing payments on quality creates an indirect incentive to resolve staffing problems, as nurse activities are directly linked to the content of each program. Preventing healthcare acquired conditions and unnecessary readmissions are prime examples of this condition. Even with the indirect support provided by the Affordable Care Act, unfortunately, nurse staffing issues remain, and is why nurses continue to strive for federal support. Connecticut-specific legislation. Connecticut currently has 2 active laws that apply to nurse staffing, both of which have been updated since the Affordable Care Act was passed in 2010. The first, Connecticut General Statute 19A-89D, requires the Department of Public Health to have a single method for collecting and analyzing data concerning the link between nurse staffing levels and quality of care. This statute also requires the Department of Public Health to conduct an ongoing study of the outcomes collected and make that data available to the general public. The second active statute, Connecticut General Statute 19A-89E, requires that each Connecticut hospital licensed by the Department of Public Health, must report annually on a prospective nurse staffing plan that is sufficient to provide adequate and appropriate delivery of healthcare services. The plan must promote collaborative practice at the hospital level to enhance patient care. Additionally, the second statute requires the creation of staffing committees at each to oversee the development and management of the mandatory staffing plan. At least 50% of the staffing committee must be comprised of RNs involved in direct patient care. Another requirement of the second statute is that hospitals specify the number of RNs providing direct patient care and the ratio of patients to RNs by patient care unit. Recommendations. Finally, we will present some recommendations going forward. First, hire more nurses. It has a direct link to reducing adverse incidents in patients. Second, increase the nurse-patient ratio in hospital and nursing home settings. Third, encourage nurses to minimize working more than 60 hours in a 7-day period to avoid burnout. Finally, encourage nurses and managers to be involved in the direct needs of the department and to create a nurse-patient ratio that is flexible to accommodate the demands of our population. Whether a healthcare employee, a patient, or the family member of a patient, the impact of nurses in the acute care setting cannot be ignored. Research shows that increased attention from nursing staff improves patient outcomes. Over the past several years, legislation to establish specific nurse-to-patient ratios has been introduced and failed repeatedly. A compromise must be reached between hospital corporations and nurse organizations to ensure profits are achieved without compromising safe, quality patient care.